Welcome to the deep dive. Today we're getting into a specific set of revision notes all about enteric fever.
That's right, covering both typhoid and paratyphoid fever.
Yeah, exactly. And our mission really is just to pull out the key facts, the high-yield stuff from this material.
Strictly focusing on what these notes actually say.
Perfect for a quick revision overview, getting those essential points locked in.
Right. So, okay, let's unpack this then.
Let's do it. Where do the notes start? Definition.
Yeah, starts with the basics. Enteric fever is defined as a systemic infection.
Systemic, meaning whole body, not just like a gut bug.
Precisely. It affects multiple organs. And the notes name the specific culprits.
Which are?
Salmonella enterica. But, crucially, specific serotypes. Typhi causing typhoid fever, and Paratyphi A, B, and C causing paratyphoid.
Okay. So it's Salmonella, but it's important to know it's these specific types causing the systemic illness.
Yes, the notes make that distinction clear. While the wider Salmonella group often causes diarrheal diseases, these particular ones, Typhi and Paratyphi, they cause this prolonged fever, headache, body aches, systemic symptoms, not just diarrhea.
Got it. And how do we actually get infected with these? The etiology.
Well, according to the notes, it's primarily through ingesting contaminated food or water.
Okay. Contaminated with the bacteria, obviously.
Yeah, bacteria shed in the feces of infected people. So it really boils down to a fecal-oral route.
Simple, but unfortunately effective transmission.
It is. And that leads straight into the risk factors mentioned.
Makes sense. Poor sanitation.
Exactly. Poor sanitation, inadequate hygiene, lack of clean water. The notes highlight residing in or traveling to areas like that.
So travel history is key.
Absolutely.
Yeah.
Plus, obviously, actually consuming the contaminated food or water
Mm-hmm.
and close contact with someone already infected.
Right. Any specific jobs mentioned?
Yeah, the notes point out healthcare workers and food handlers as potentially being at higher risk due to exposure or, well, their role in handling food.
Okay. So the bacteria gets ingested. What happens next? This is the pathophysiology bit, right? Where it gets really interesting.
Yeah, this is a journey. So after ingestion, the bacteria invade the lining of the intestine. But here's the clever, or maybe sinister part mentioned in the notes. They get taken up by macrophages, our own immune cells.
The ones that are supposed to kill bacteria?
Exactly. But Salmonella, Typhi, and Paratyphi can survive, even multiply inside these macrophages.
Wow. So they sort of hijack them.
Pretty much.
Mm.
They use them to travel. The infected macrophages enter the bloodstream. That's the bacteremia stage.
Bacteria in the blood.
And that allows them to spread everywhere, disseminate to the liver, spleen, bone marrow, other organs.
Using our own defenses against us. That's,
Right.
Yeah, concerning.
It is. And the body's immune response to this invasion causes the inflammation and tissue damage that lead to all those systemic symptoms like fever and aches.
And does it stop there? Or is there more to the cycle?
There's a bit more. The notes mention the gallbladder. The bacteria can set up shop there, multiply, and then get excreted in bile back into the intestines.
So it gets shed in the feces again?
Right, completing the cycle and allowing transmission to others. Fecal-oral route again.
A pretty complete and unfortunately effective life cycle within the host. Okay, so diagnosing this. Prolonged fever, systemic symptoms. Sounds like it could be a lot of things.
It absolutely could, and the notes emphasize this. The differential diagnosis is broad because the symptoms are nonspecific. And enteric fever can be a real great masquerader.
So this raises an important question. What else needs to be on the list? What other conditions present like this?
Well, the notes suggest considering other bacterial infections like brucellosis, for example.
Okay.
Viral infections too. Infectious mononucleosis, or mono is mentioned.
Right.
Parasitic infections, definitely. Malaria is a big one, especially with travel history.
Always consider malaria with fever and travel.
Always. And even non-infectious causes, like autoimmune diseases. Systemic lupus erythematosus, SLE, is specifically listed in the notes.
So quite a wide net you have to cast initially. Now, thinking about the UK specifically, how common is enteric fever here?
Generally rare, according to the notes. It's not endemic.
So where do UK cases usually come from?
Primarily travelers. People who've been to endemic regions, parts of Asia, Africa, Latin America, or sometimes people who have had close contact with a return traveler who's infected.
So again, that travel history is just fundamental in a non-endemic setting like the UK.
Absolutely crucial. The incidence here is really driven by global travel and migration.
Okay. Let's talk about the clinical picture then. What does it actually look like when someone presents? You mentioned the fever.
Yeah, the notes describe a classic pattern.
Mm-hmm.
It starts gradually, increases, and then becomes this sustained high fever, potentially lasting for weeks if it's not treated.
Not usually a sudden spike, more of a slow buildup than sustained.
That's the typical picture described. And alongside the fever, common symptoms include abdominal pain, headache, malaise, just feeling generally unwell.
Loss of appetite.
Yeah, anorexia, generalized body weakness. And here's that interesting point again. Constipation is noted as being more common, especially early on in typhoid, even though you might expect diarrhea with salmonella.
That's a really useful clinical pearl. Constipation and typhoid. Diarrhea can happen too, though.
It can, yeah, maybe later in the illness, but constipation first is a classic pointer for typhoid specifically.
Good to remember. What about that rash? Rose spots.
Yes, the rose-colored rash. Described as being on the abdomen and chest, the trunk. The notes say it occurs in about 40% of patients.
Not everyone gets it then.
No. And interestingly, the notes mentioned it's actually more common in paratyphoid cases compared to typhoid.
Ah, another subtle distinction. Anything else on examination?
Relative bradycardias is highlighted.
Meaning the pulse is slower than you'd expect for that level of fever.
Exactly. The Fadget sign, sometimes called abdominal distension, can also be seen. And of course, in severe cases, you might see signs pointing towards the complications we'll discuss later, like peritonitis from perforation.
Okay. Given these sometimes vague symptoms, how do we actually confirm the diagnosis? What investigations are key?
Gold standard, according to the notes, is blood cultures.
Makes sense. Find the bacteria in the blood during that bacteremia phase.
Precisely. Especially important early in the illness. That's your best shot at isolating and identifying the specific Salmonella serotype.
Are there other tests mentioned?
Yes, serological tests like the Whittle test are listed. But these detect antibodies, and the notes sort of imply caution antibody results can be tricky to interpret, influenced by past infections or vaccination, not as definitive as culture.
Right. Direct detection is better.
Generally, yes. Molecular tests like PCR for the bacterial DNA are also mentioned as options for rapid detection.
Okay. And stool cultures.
Useful too, mentioned for identifying carriers later on, or sometimes later in the illness, but blood cultures are emphasized as the primary diagnostic tool early on.
Got it. Blood cultures, first and foremost. So, once you have a diagnosis, how is it managed, particularly thinking about the UK context?
Right. Management hinges on antibiotics. That's the cornerstone.
Which ones?
The notes mention fluoroquinolones, like ciprofloxacin, or third-generation cephalosporins, like ceftriaxone, as typical choices.
But there's a catch, isn't there? Resistance.
A huge catch. Antibiotic resistance is a major issue globally with Salmonella typhi and Paratyphi. So the notes stress that treatment must be guided by susceptibility testing. You need to know which antibiotics will actually work against the specific strain the patient has.
You can't just follow a standard recipe. You need the lab results.
Absolutely. The UK has national guidelines, which are updated based on current resistance patterns, but individual susceptibilities are key.
And besides antibiotics?
Supportive care is crucial. Hydration, managing the fever, pain relief, ensuring good nutrition, especially if someone's been ill for weeks.
Makes sense. And prevention.
Vaccination is mentioned, recommended for people traveling to high-risk endemic areas.
Oh, okay, good. So, prognosis. What's the outlook, and what are the dangers if things go wrong?
With prompt, appropriate antibiotic treatment, the notes say the prognosis is generally good, favorable.
But the if treatment is delayed or the bug is resistant.
That's when serious complications can occur. The notes list some really critical ones.
Right.
Intestinal perforation, a hole in the bowel, that's a surgical emergency. Also significant gastrointestinal bleeding.
Nasty.
Yeah. And organ dysfunction problems with the liver or kidneys. And ultimately sepsis, which is that overwhelming life-threatening body response to infection.
Okay. Any other specific complications highlighted?
Yes. Chronic carriage is mentioned. This is where someone recovers but keeps shedding bacteria in their feces for a long time, potentially months or years.
Wow, that's a public health issue.
It is. The notes say it's rare, but more common in adult females, and often linked to gallbladder issues like gallstones.
Interesting link. Anything else?
Osteomyelitis bone infection is listed, with a specific note that it's particularly common in patients with sickle cell disease who get enteric fever.
That's a very specific point. Good for revision.
Definitely.
Yeah.
Also meningitis infection around the brain and spinal cord, and cholecystitis, which is inflammation of the gallbladder itself.
Right. So quite a range of potential problems if not caught and treated properly. Okay, so let's just sort of recap the journey we've taken through these notes.
We started with the definition, systemic infection by specific Salmonella types.
Looked at how it spreads fecal-oral, linked to sanitation.
Dived into that fascinating pathophysiology, invading the gut, hijacking macrophages, spreading via the blood.
Setting up shop in organs like the liver, spleen, bone marrow, even the gallbladder.
Then the clinical features, that gradual, sustained fever, the headache, abdominal pain, the surprise constipation and typhoid, the rose spots.
And the importance of considering it in the differential for prolonged fever, especially with travel history.
Yeah, remembering it can mimic lots of other things.
Investigation's blood culture being key.
Absolutely. And management with antibiotics, but always guided by susceptibility testing because of resistance.
Plus supportive care. And finally, the potential complications if things aren't managed well: perforation, bleeding, sepsis, chronic carriage, osteomyelitis, especially in sickle cell.
It really covers the whole spectrum, from transmission to severe complications.
So what does this all mean, pulling it together? You see how the transmission via poor sanitation links directly to risk factors like travel.
And how that clever pathophysiology, using macrophages, explains why it becomes a systemic illness affecting multiple organs, not just the gut.
Which in turn explains why the symptoms can be so varied and nonspecific, making the differential diagnosis so important.
Especially in places like the UK, where you rely heavily on spotting those risk factors, like travel.
Exactly. Understanding these connections is really key to getting a handle on enteric fever based on this material.
That link between the bug's behavior inside the body and the clinical presentation is crucial.
Definitely. So as a final thought for you, maybe consider this. Enteric fever really highlights that intersection between, on one hand, massive global health challenges tied to basic things like clean water and sanitation.
Yeah, where outbreaks can cause huge problems, often quite silently compared to other diseases, maybe.
Right. And on the other hand, the intricate clinical challenge it presents diagnosing this great mass greater based on often vague symptoms, and the absolute need for the right investigations, like blood cultures, early on.
It's a disease that operates on both that huge public health scale and that very specific, demanding clinical level, something to keep in mind.
We really hope this deep dive, focusing just on these revision notes for enteric fever, has helped clarify things and given you those high-yield takeaways.
Yeah, hopefully a useful session, especially if you're revising for something like the MSRA. It's a core infectious disease topic.
And if you are looking for more revision resources, definitely check out passmansray.com.
And also freemsesray.com for more materials.
Thanks for tuning in to this deep dive.
See you next time.